I'm glad to be here. My name is Keiji Ninomiya from Melody International. So please make sure that the mic is off, please. And then probably most of people are still waiting, joining us, but I think it's okay. So let us start our CTG telediagnosis online lecture. So first, I'd like to welcome to you all, and we'd like to have welcome greetings from Professor Masaaki Tokuda, Vice President of Kagawa University, who hosted this webinar. Please, Professor Tokuda, please.
Thank you very much, Mr. Ninomiya. Nice to see you all, and welcome to our webinar. This is the second time to provide this webinar of CTG telemedicine, and this time we do it in English. Okay, so I'm Vice President of Kagawa University, who is in charge of international affairs and also international research collaboration. Okay, so I wish to promote more collaboration with the other universities all over the world. Okay, so let me show you my slides. Oh, this one. Okay, you can see it, right? Okay, so today we have okay, today we have, oh, come on, sure. We have two wonderful professors, Professor Hara and Professor Baba, to explain our activities. Okay, so I hope you enjoyed their lectures. Okay, so let me introduce briefly about the Kagawa University. Kagawa University, which is in Kagawa Prefecture, is located here. Okay, so it's a southern part of Japan on Shikoku Island. And Kagawa University has 6 faculties: education, agriculture, law, engineering and design, economics and medicine, and 7 graduate programs, graduate schools. Well, we have about 6,500 students, not very big university, middle-sized university in Japan. And then we, per year, we have about 350 to 400 inbound international students. And then about 270 Japanese students go outbound, that means study abroad. And now we have 99 partner universities all over the world, a lot in China. And Kagawa University achieves global initiatives based upon SDGs. Today's lecture is also, today's our activity, telemedicine, is deeply related to SDGs. So let me introduce several of our global international initiatives. Okay, since we have, today we have many people from many countries, such as China, Myanmar, Kenya, Cambodia, Bhutan, and Malaysia. So this activity is a school health system in Cambodia. And we did it under JICA project. And then we will try to develop a school health system in elementary schools, in Cambodia, near Phnom Penh. So we've been very successful to make a textbook in Khmer language, their own language, as well as English. And then other activities such as hand washing, teeth washing, and then lots of seminars and training courses we are doing in Cambodia. The research which I myself is deeply involved in is a rare sugar project. rare sugars are the natural sugar, which has function. So function and very low calorie, almost zero, and sweeteners. That is good for the prevention of non-communicable diseases. So we already finished the innovation of pure diarylose, and then rare sugar containing syrup. So we already, the function it can be the prevention of the diabetes mellitus, obesity, atherosclerosis, and dental caries. So we've been already starting international collaboration with Chiang Mai University, Thailand, University of Brunei Darussalam in Brunei, and then University of Florida in USA. The third one in international initiative is disaster mitigation researches in earthquake-prone countries. Japan is an earthquake-prone country, so we have lots of earthquakes, and sometimes we have tsunami and floodings and other natural disasters. So we are very top-level researchers in Japan, and then already started lots of international collaboration. So you're welcome to access us to start the next collaboration with you. And finally, I'd like to introduce our ICT telemedicine project, right? So today we will explain more about two professors, Professor Hala and Professor Baba. Okay, so we started about 15 or a long time ago. Okay, and then first in Kagawa, and then Japan, and now we are doing lots of collaborations in international collaborations with many countries all over the world. Okay. And then let me introduce this very happy thing. Our team, myself, Professor Hala, and Ms. Ogata and Mr. Ninomiya, and then two people from NPO ESIC got award of science, technology, and innovation for SDGs in 2020 from Japan Science and Technology Agency. That is the branch of the Ministry of Education. So tomorrow, actually, we'll have the award, receiving ceremony, and then we are very happy to provide this lecture one day before the award the receiving ceremony. So this is just a brief introduction about the Kagawa University and our international initiative. And then today, we are very happy to explain the fourth one, so the telemedicine project for you. And then I hope you enjoy our web lectures. Thank you very much.
Thank you, Professor Tokuda. So now we a bit studied about our area, Kagawa and Kagawa University. So the next, move on to the next lecture. So before lecture, so we will be happy to take your question. If you have a question, please write your question for on the chat box for all of us. And we will respond to it after the entire lecture, after Professor Hara and Professor Baba, and after that, so we will nominate the question. So please put the question on the chat box, please. So then I'd like to welcome our first speaker, Professor Kazuhiro Hara, Director General of the Executive Committee of Telemedicine Support Project, which is in charge of JICA project in Chiang Mai, Thailand, in Chiang Mai. And he's also the specially appointed professor at Kagawa University, Seto Inland Sea, which is now you can see the blue beautiful sea in Seto Inland Sea Regional Research Center. So the title is you can see the webinar title. So Please, Professor Hara.
Thank you. Thank you very much, Vice President Tokuda and Mr. Inomiya. I am Kazuhiro Hara of Kagawa University. I am very honored. 聞こえてますか？大丈夫です。I am honored to have many participants from 6 countries attending this webinar. Today, Japan's perinatal mortality rate and maternal mortality rate are the lowest in the world. I have been asked by some people from the other countries how Japan achieved such low mortality rate. This slide shows the maternal and fetal neonatal mortality rate in the world. At present, it can be seen that maternal deaths and fetal neonatal deaths are extremely low in Japan compared to other countries. The mortality rate in China, India, and Africa are quite high. In some countries, it is about 100 times more than Japan. How to reduce this high mortality rate is the main theme of the JICA grassroots project now in Thailand, Chiang Mai. I graduated from medical school about 40 years ago. At that time, the maternal mortality rate and fetal neonatal mortality rate in Japan were also high. And my research theme at that time was how to lower it. It was also the research theme of Professor Baba, who will talk about today. By the way, the method of reducing maternal mortality rate is almost completely decided. It is very important to diagnose preeclampsia, blood group incompatibility, placenta previa, and preterm birth at early stage, and send high-risk patients to a well-equipped core hospital as soon as possible. Even in Japan, 40 years ago, fetal asphyxia and neonatal asphyxia occasionally occurred during delivery. The research theme at that time was how to get the fetus to be born safely at the time of delivery. That is why at that time research on fetal heart rate was so advanced. It was very important how to detect the fetal heart rate accurately during labor. And there was competition for research and development all over the world, especially in Germany, United States, and Japan. After that, in Japan, fetal monitors have come to be used during all deliveries. And as the performance of the fetal monitors improves, it has become a policy to use fetal monitor not only during delivery, but also during pregnancy. As a result, the fetal neonatal mortality rates have dropped significantly in Japan. For that reason, detection of fetal heart rate is very important at all times from pregnancy to delivery. This method allows high-risk pregnant women to be transferred early to the core hospitals. Even in Japan in the old days, it was practiced to transport the newborn baby to a higher hospital after birth. But now it is a principle to transport the pregnant woman before giving birth. That means together the mother and the fetus in uterus. Therefore, if the heart rate pattern during pregnancy can be shared with clinic and university hospital or hospital, even better results can be obtained. For that purpose, using mobile fetal monitor, we are working on the entire Chiang Mai prefecture now by JICA project. This is a fetal monitor developed by Hewlett-Packard company in Germany about 40 years. So the very, very old type. At that time, in Germany and United States and Japan, we are competing for the development of fetal monitors. And the fetal monitors from these 3 countries are now widespread throughout the world. Until then, midwives used a so-called travel stethoscope to count the fetal heart rate of the fetal heart rate. I still remember those days. On the other hand, when measured with a fetal monitor, it's recorded very cleanly as a continuous heart rate pattern. At the beginning of the development of fetal monitor, the fetal heart rate could not be obtained well. So when delivery started and the uterine ostium opened, then an electrode was attached to the fetal head to take the ECG signal. The ECG signal is very clean waveform, but it can only be used during labor. In addition, it is not easy to attach an electrode to the fetal head. It's not so easy to attach this electrode. Therefore, other methods are absolutely necessary to use a fetal monitoring during pregnancy. And many studies have shown that using ultrasound is the most effective. This is a waveform from fetal ECG from the head, fetal head. This signal is very clean and simple. For example, if the duration from here to here is 1 second, then heartbeat is 60 beats. And when this duration 0.5, then 120. And then this is a waveform of ultrasound. Very complicated, and the peak is not, it is very difficult to find the peak. In this case, it's not clear where the peak is. Therefore, it is very difficult to measure accurate heart rate by so-called peak trigger circuit. We use peak trigger circuit for ECG. However, for concerning Doppler, it is very difficult to use peak trigger circuit. Forty years ago, we are competing with companies around the world to get the exact heart rate from this complex waveform, similar to the waveform obtained from ECG. If you like mathematics, you may have heard about Fourier transformation. By using this method, Fourier transformation, it is found that even if the ultrasound is used, a very clear heart rate pattern can be obtained compared with the heart rate pattern from the ECG signal. This fetal heart rate pattern is from ECG signal. This heart rate pattern is obtained from this complex, very complicated ultrasound waveform. This is the method we developed at the Department of Obstetrics and Gynecology at the University of Tokyo 40 years ago. Then a representative from Hewlett Packard Company came to Japan and offered us to use our method using Fourier transformation. And it was then introduced to Hewlett Packard's fetal monitor and have become a global standard. The condition of the fetus cannot be diagnosed simply by listening to the sound of fetal heart rate for 5 seconds. Instead, a much more accurate diagnosis is possible using the fetal heart rate pattern. However, conventional fetal monitor is large and heavy, so it can only be used in the hospital. If this device becomes smaller and can be used on mobile, it can be used effectively in various situations such as remote use or telemedicine. Therefore, we developed this small device in 2006, which was used in Chiang Mai University, 6 years ago. It was 2001, 19 years ago. The Japanese princess, now Her Majesty the Empress, actually used this device when giving birth. The photo on the right is from when His and Her Majesty of Bhutan came to Japan 9 years ago. They were also very popular in Japan. Just this spring, Her Majesty was pregnant with her second child. I was hoping that she would use this device. Fortunately, she actually used this device. In addition, the government of Bhutan has decided to introduce this device throughout Bhutan. The device on the top left, this slide is a Hewlett Packard fetal monitor used in the hospital. Now global standard type. This small fetal monitor that can be used on mobile since 6 years, this type was used in Chiang Mai. This PUT-CTG is newly developed ultra small mobile CTG, PUT-CTG. Currently, it's used in Chiang Mai Prefecture, and as a test, it is used in various countries such as Myanmar, Indonesia, and also in Africa. For example, South Africa or Zambia. And now it is planned to be introduced in Ghana and Nigeria in the future. Just my daughter got pregnant with her third child and sent me a heart rate with PUT-CTG. For my research, my daughter sent me a very accurate fetal heart rate. The heart rate has been sent without a miscount for 20 minutes. There's no miscount, very clear. The FOOTIS-CTG has very good performance, so if you attach it firmly to the appropriate place of the abdominal wall of the pregnant woman, you can always detect the fetal heart rate so accurate like this. Since the fetus wakes up or sleeps in the uterus in about 20 minutes, the heart rate pattern that fluctuates and up and down here means the fetus is awake, and here means fetus is sleeping. As such, fetal heart rate pattern are clinically very important. So I hope that you will study the diagnostic method of fetal heart rate pattern in the next lecture by Professor Baba. By the way, Professor Spatula of Chiang Mai University received a wonderful award from the Thai government for JICA's first project in Chiang Mai. I think you all know Japanese former Prime Minister Abe. The Japanese government was also very interested in this FOOTIS-CTG, and it was a great honor for us to be called to the Prime Minister's office. This is a commemorative photo with former Prime Minister Abe at the time. Professor Spatula has been commended by the Thai government, and we are also commended by Japanese government. I sincerely believe that this project is very, very valuable. We are currently working on these projects in Japan and Chiang Mai, and it will spread all over the world in the future. We ask for your understanding and support so that this project will spread throughout the world in the future. While the government of Japan was interested in the development of our FOOTIS-CTG, and in the program called NHK World, our efforts were introduced to all over the world. So I would like to introduce this broadcast to you. Please, Mr. Ninomiya.
Thank you, Professor Hara. So the interesting lecture. So as he said, so I'm going to share the video program of the NHK, which is the Japanese national broadcast. Program name is NHK World Science View and J Innovators. So let me share the program. Okay, thank you for watching the TV program. So, Hara Sensei, これで大丈夫でしょうか? Okay, the Professor Hara's lecture has been finished, and then next, today's second lecture is I would like to introduce Professor Kazunori Baba. He's a professor of Center for Maternal, Fetal, and Neonatal Medicine, Saitama Medical Center, and Saitama University. So the title is How to Read the CTG Pattern. This is the introduction. So please, Professor Baba, let you start the lecture, please.
Hello, everyone. Can you hear me? Okay, thank you. I'm Professor Baba. Nice to meet you. Let me see. Oh, this is Japanese map of Japan. Here, Kagawa, and I'm speaking from Saitama, near Tokyo. Okay, and this is a Saitama Medical Center, my hospital, and Saitama Medical Center of Saitama Medical University. And this this building is a Center for Maternal Fetal and Neonatal Medicine in the Saito Medical Center. This shows NICU in Saito Medical Center. We have a 60 bed in our NICU, okay? And most of premature babies, even born at 500 grams or at 24 weeks, survive and grow up. And a happy reunion of NICU graduates with their parents. This is a photo of the small babies. But there's some babies in the NICU. As you see, this is an old photo, not a current one, but this baby has a permanent brain damage caused by hypoxia during labor. So today's my talk is for safe delivery. As you know, fetus tend to become hypoxic during labor. If the hypoxia is severe, the baby will die or have severe sequelae. What can we do to prevent the baby's death or sequelae like brain disorder caused by hypoxia during labor? First, monitoring of oxygen concentration in the fetal blood continuously, and proper intervention should be done immediately when an abnormality occurs. As you know, this is a pulse oximeter. Pulse oximeter can measure oxygen saturation level in the blood non-invasively and continuously. But pulse oximeter cannot be attached to the fetus in the uterus. There's no way to measure the fetal blood oxygen concentration non-invasively, continuously, and real-timely. That's a problem. Cardiotomographs or electric fetal monitors are used worldwide instead of pulse oximeters. Why? As you know, the cardiovascular center in the brain regulates the heart rate through the sympathetic and parasympathetic system. And the cardiovascular center decides the heart rate according to the signal from the chemoreceptors and the basoreceptors, and also the cerebrum. That means heart rate is controlled by blood gas and blood gas concentration and blood pressure and cerebrum. So although indirectly, we can see whether the fetus is hypoxic or not, and whether the brain is working normally or not by monitoring of the fetal heart rate. Cardiotomographs are used during labor and during pregnancy. First, I'll talk about the CTG during labor. This is a sample of the cardiotomogram, okay? In other words, the CTG. The Japan Society of Obstetrics and Gynecology recommends the paper speed is 3 centimeters per second per minute. This shows uterine contraction, and this is a heart rate curve. First, normal CTG. We can say this is a normal CTG. Four conditions are met. We can say that it is a normal. What is the four conditions? First, look at this relatively stable parts here and here. And magnified this. You can see the heart rate is a little bit up and down and up and down. You can see the fluctuation, but you can see the average here. The average of this part, relatively stable part period, is called baseline. Baseline is approximate average fetal heart rate during 10 minutes segment is rounded to the nearest 5 beats per minute increments. So this is in this case, the baseline is 140 beat per minute, not 141, not 139, but 140, okay? And the normal range of baseline is 110 to 160. This is a first condition of the normal CTG. And look at this. You can see the fluctuation here. It's called the variability, okay? And the amplitude of the variability is very important. Moderate variability, the amplitude is 6 to 25 beat per minute is a second condition of for the normal CTG. While moderate variability is important to judge the fetus is in good condition. As you know, the heart rate is controlled by the cardiovascular center. And if the heart rate is a little bit go up, then the parasympathetic nerve works and return to the original position, but exceeded go down. And sympathetic nerve works and parasympathetic works. So you can see the fluctuation. So you can see the fluctuation because of the cardiovascular, both cardiovascular center and the sympathetic and parasympathetic nerve system are working properly. So variability is very important for the normal CTG. And the third condition is acceleration. You can see episodic or periodic increase of the fetal heart rate here. This is called acceleration. Acceleration is, existence of acceleration is very important. That's because, for example, some of you are surprised and your heartbeat is going up. That's because your brain reacts to the stimulation and heart rate is up. That's acceleration. So any stimulation, for example, the uterine contractions or the fetal movement or fetal touch the uterine wall, anything. Anyway, the stimulation cerebrum reacts stimulation, and through the sympathetic nerve, the heart rate go up and return to the original position. This is acceleration. So acceleration is important to prove the brain is works properly. Okay, but remember, if you say that it's acceleration, the acceleration needs more than 15 beat per BPM increase, more than 15 BPM and lasting more than 15 seconds, okay? 15 by 15. It's a definition, okay? But remember, before 32 weeks of gestation, it's a 10 and 10 BPM and 10 second. And the fourth condition for the normal CTG is no deceleration. There's no deceleration is very important, okay? So in summary, 4 conditions are met. We can say it's a normal CTG. Baseline between 110 to 160, and variability, amplitude of the fluctuation is 6 ppm to 25, and acceleration, yes. Deceleration, no. Okay, this is a normal CTG. And decelerations. Deceleration is a temporary drop of the fetal heart rate. There are 4 decelerations: early decelerations, late deceleration, variable deceleration, and prolonged deceleration. This is deceleration. You see, temporal drop of the fetal heart rate, but this is not abnormal. You see, this is uterine contraction. The peak of uterine contraction and the minimum heart rate is the coincident, the same time. This is called early deceleration. Early deceleration. What causes early deceleration? It's because of the head compression. The uterus contracts, and the fetus is compressed and pushed, and the fetal head is pushed. The pressure to the fetal head. The pressure transmitted to the brain directly because the fetal head cranial bone is not fixed. So the pressure stimulation stimulates the parasympathetic system more than the sympathetic system. So the fetal heart rate decrease. This is a mechanism of the early deceleration. So it's normal. We can see the early deceleration several times just around the end of the second stage of labor. It's normal. This pattern, it looks like early deceleration, but this is abnormal. It's called the late deceleration. Look at this. You can see the uterine contraction, the peak of the uterine contraction, and the minimum of the, or the nadir of the fetal heart rate is a delay, not coincident. This is a late deceleration. What causes the late deceleration? In this point, just before the uterine contraction, the fetus and placenta and the umbilical artery, uterine artery, you see the both in the placenta and the fetus, there is sufficient oxygen, so no decelerations. But if the uterine contracts, the blood vessels in the uterine wall compressed and stop the blood flow to the placenta. So in the placenta, oxygen concentration decreased, but in the fetus, enough oxygen is maintained, so no decelerations. Uterine contract, but no deceleration. But here, the blood without oxygen enough, with oxygen not sufficient, goes to the fetus gradually. So the chemoreceptor in the fetus react and go down. The fetal heart rate is going down slowly, gradually. And after peak of the uterine contraction, the blood flow to the placenta is resumed, but in the umbilical cord and in the fetus, still lack of oxygen. So the still go down, the fetal heart rate is go down. And after the uterine contraction is over, then the oxygen come to the fetus gradually and go up. Fetal heart rates go up, and here recover. The heart rate is recover. So there's a delay because of the blood flow go through the umbilical vein, and this changes gradually. So the point is the change of the fetal heart rate is gradually. But you wonder if such a mechanism occur, all fetus show the rate deceleration, but most of normal fetus doesn't show the rate deceleration. It's a threshold. Okay. Sorry. Most of the normal fetuses has enough oxygen in its body, so the oxygen concentration is also the drop in the normal fetus, but the threshold is here. So chemoreceptor doesn't react if the oxygen concentration is not reached or exceeds the threshold. So in normal cases, the oxygen concentration in the fetal blood does not reach to the threshold. So nothing has happened, no deceleration. But fetuses with a low oxygen concentration before the uterine contraction, it's easy to reach and exceed the threshold. So decelerations occur. So that means in this case, the fetal condition is not good. Insufficiency of the placenta. And next abnormal CTG deceleration is a variable deceleration. Here, in the early deceleration and late deceleration, the change is gradually, but variable deceleration is abrupt. Suddenly drop down and suddenly go up. And each pattern is different. It's a variable deceleration. What causes variable deceleration? It's cord compression. If the cord is compressed, what happens? Cord compressed, the heart press the blood, but blood doesn't go to the placenta smoothly. So what happens? Blood pressures go up, and baroreceptor react, and cardiovascular center works the parasympathetic nerve, and decelerations occur. And just after the compression is over, the vice versa, go up or no, go up, return to the normal range, normal level. So the variable deceleration is an abrupt drop and abrupt return. And the third deceleration is a prolonged deceleration. If the deceleration lasts more than 2 minutes and less than 10 minutes, it's called a prolonged deceleration. It's a kind of the severe rate deceleration or the variable deceleration. It's a severe type. You see, 2 minutes, it's an important number. In this case, look at the uterine contraction. Pay attention to the uterine contraction. Usually, uterine contraction lasts 60 to 80 seconds, but in this case, more than 90 seconds. It's an abnormal uterine contraction. Uterine contraction usually doesn't last more than 90 seconds. So the abnormal uterine contraction causes this prolonged deceleration. And bradycardia. If the deceleration lasts more than 10 minutes, we don't think it's a deceleration, but the baseline is shifted. So if the deceleration lasts more than 10 seconds, it's called bradycardia. So how about the tachycardia? The baseline is over 160 bpm. which called tachycardia. It's abnormal. Yes, it's abnormal, but it's not so severe. What's caused tachycardia? For example, if the blood oxygen concentration in the fetal blood is a little bit go down, the heartbeat go up, and to maintain the supply of the oxygen to the brain. So it's not a severe condition, but it's a kind of abnormal. But remember, the most common cause of tachycardia is maternal pyremia. So if you see the tachycardia, check first the maternal fever. And as you know, as I mentioned before, normal CTG has a moderate variability. Okay. In this case, we can see the detector variability very small. Fluctuation is very small. It's the fifth abnormal CTG is undetectable or minimal variability. Undetectable or absent, we sometimes call it loss of variability, flat line. And minimum or reduced variability means variability is less than 5 BPM. This is a 5 BPM range, okay? What is the problem, the minimum or the absence of the variability? As I said before, the cardiovascular center and parasympathetic nerve and sympathetic nerve control the fetal heart. So variability caused by the cardiovascular center, both nerve systems. So if you see the, we can't see the variability, these systems doesn't work. So this is a very important sign. And this 4 pattern, CTG pattern is needs emergency intervention. Repeated rate decelerations with no variability or absent variability or loss of variability, and repeated variable decelerations and loss of variability, and prolonged deceleration and with loss of variability. It's very important. You need emergency interventions, cesarean sections, or forceps delivery, vacuum extractions, anything. You should deliver the baby immediately. And also the severe bradycardia. Severe means less than 80 BPM. And with variability less than 5 BPM. It's also very severe conditions. And this is a unique pattern. It's also the abnormal CTG. It's called the sinusoidal pattern, regular smooth sine curve. You see the sine curve, sine wave with no acceleration, lasting more than 10 minutes. Frequency is 2 to 6 cycles per minute, and the amplitude is between 5 to 15 BPM, not exceeded 25 BPM. This is a sinusoidal pattern. And this sinusoidal pattern means shows usually the severe fetal anemia and fetal hypoxia. And next, I talk about CTG during pregnancy. It's called the no-stress test because of the no stress of the uterine contractions. It's we do the NST for the evaluation of fetal well-being and evaluate uterine contractions in the certain premature labor cases. Okay, and normal CTG during pregnancy is also the same 4 conditions. Baseline between 110 to 160, and variability, mild variability 6 to 25. Acceleration, yes. Deceleration, no. Plus, during pregnancy, uterine contraction, no. So the 5 conditions for normal CTG during pregnancies. How about this heart rate, fetal heart rate? It's abnormal. Baseline 140. It's normal. Okay. No deceleration. It's okay. But how about the variability? Variability is less than 5. So it's a minimum or reduced. And the acceleration, no. It's abnormal. But remember, the fetus is sleep and wake up in 20 minutes to 40 minutes. So in the period of the fetus is sleeping deeply, variability and the acceleration is reduced. So you shouldn't evaluate variability, acceleration during the fetal sleeping period deeply. So we usually do the NST, no stress test, for the more than 40 minutes to avoid the fetal sleeping period. Okay, remember, variability and acceleration are suppressed during deep sleep. So avoid this period to evaluate NST or CTG during pregnancy. And precaution of the NST result interpretation. Okay, normal CTG means fetal well-being is good. It's true, but not normal CTG during pregnancy. Fetal well-being is bad. It's not true. It's not true. Okay. This shows illustrates fetal well-being. Green shows well-being is good, and red is bad, and yellow is intermediate. Okay. Some fetus is in good, well-being is good. Non-stress test is normal, but some is non-stress is not normal. I mean the 4 conditions is one of or 2 conditions are missing. So the non-stress test is for reassuring, but not to detect distressed fetus. It's a very important point. NST, normal fetal well-being is good. It's true, but not normal fetal well-being is bad. It's not true, okay? And abnormal CTG during pregnancy. If you see the red deceleration, variable deceleration, prolonged deceleration, bradycardia, it's abnormal, even in the during pregnancy. But during pregnancy, don't miss a very shallow deceleration like this. Here, you can see the very shallow deceleration. You should miss this. And look at this. Very small or very weak uterine contraction. This pattern is a late deceleration. Okay, so don't miss this small change during pregnancy or the NST. I'll show the typical change of the CTG according to the progress of the hypoxia and metabolic acidosis. First, let deceleration appear. Let deceleration appear here. Then acceleration is disappear. And more getting worse, variability is reduced. And finally, no variability, no acceleration, rate deceleration. It's a very severe cases, okay? It's a typical one. There's no many exceptions, but it's a typical one, okay? One last word. Listen to the fetal heart tone is very important. It's true, but seeing CTG is more important. Why? You can see this is an early deceleration. This is a late deceleration. It's not abnormal, but this is abnormal. Okay, you can't distinguish these two decelerations only by listening, but you can see by graphs. How about this? It's a normal variability, no loss of variability. You can distinguish these two situations only by listening, and you can miss the very shallow rate decelerations only by listening. So to see the CTG is very, very important. Today's my talk is for smiles of babies and their families. So let's make good use of CTG. Thank you very much for your attention.
Okay, thank you. Okay, thank you very much, Professor Baba. It was a wonderful lecture. So it's very easy to understand, such as myself, not for the specialist for the OBGY. So, and next, so also if you anybody has any questions, so please write a question in the chat box. So we are going to answer that later on. So, so now I would like to show another promotion video. So, Professor Hara Sensei, have you got any comment on the video? Okay. So let me share another video. This is some kind of telemedicine video. So drone-based e-health and remote medication. The remote island in Japan. Of course, it's in Kagawa Prefecture. And probably, maybe you will have some idea from this video. Okay. Thank you for watching the promotion video. This video is promoted by Professor Hara. So if you have any question about this video, I put the link of the video in the chat box, so you could copy it and you could see later on. So also, so we happy to have any question, but for now, so there are no question on the chat box. So if you have any questions, so just raise a hand and turn on your mic, and please ask any doctor, any professor. Any question? Okay. Okay. So any comment?
I think probably they want to make question, but to make a question the very beginning, a little bit, you know, they will be hesitate that. Okay, so I think this is a very nice system, which can be introduced in any countries, especially South Asian countries, from which country we have a participant today. So please think about, okay, if you introduce this mobile CTG, ICTG into your country, what can happen? It's quite exciting thing. So well, then okay, how I can we introduce that to our country? So from that, any kind of question or comment, and welcome. So please, today we have many participants from Bhutan, and then so we welcome questions from Bhutan, and then we have some doctors from China and Cambodia, Myanmar, right? And so yeah, let's use this opportunity efficiently. Professor Baba, Professor Hala, they are two distinguished professors in this field. So, please.
Okay. Maybe everybody so shy and
oh, someone is saying something? Okay, I have a question to you. Hara Sensei, Professor Hara showed kind of a combination of drone and medical equipment, ECG. So of course, probably mobile CTG, ICTG is also possible to bring the the drone. So I'm just wondering, in Bhutan, is drone very popular? So we can use drone in Bhutan or in Myanmar? Please ask to my question.
yes. About Dr. Nishizawa Sensei or
福田先生、コロナ
Dr. Pema
コロナ
San
の状
Sensei?
況を皆さんに聞いてください。
Maybe in Bhutan, there at this moment, kind of some another session is going on. So, okay. If anybody has a question?
Yeah, may I? Good afternoon. This is Dr. Yoriko Nishizawa from Bhutan. And thank you so much, the eminent speakers from Japan, sharing your experience of CTG. I have one question. Before maybe I ask my question, that maybe I have to answer the questions from Professor Tokuda regarding the drone usage in Bhutan. At the moment, as of my knowledge, the drone is not introduced yet, although there is a need of using because of the challenging geographical terrain. But at the moment, we are not using any drone. But we have a helicopter service, which also having multi-purpose, such as evacuating the patients and having some logistics support and all. When it comes to my questions, that these days WHO alert increasing number of cesarean section in the world, and I'm wondering how we can balance using the CTG without increasing the number of cesarean sections. If one of the speaker kindly answer my question.
Tokuda Sensei, なんか。
これ馬場先生か原先生かどちらか、
はい、
帝王切開に関係することなんで、はい。
馬場先生、お願いします。
なんか CTG の利用で帝王切開が増えるということですよね。
Okay, thank you for your very important questions. It's very important to prevent the excess treatment or the cesarean section is very important. But to prevent such a unnecessary cesarean section, just learn the CTG properly. I can say only that.
So you mean that the appropriate use of CTG is more important, and then diagnose accurately with the precise diagnosis
Yes.
by CTG, not over-diagnosing.
Yes.
Is very important. Thank you so much.
Thank you, Nishizawa Sensei and Baba Sensei. So, of course, we are going to, we would like to some clinical tests in any country to prove, to against such kind of, method of the WHO, but we are not still challenging to that project. So if in Bhutan, so would you please help us to, to prove the Professor Baba said, like not like WHO says. Okay, thank you.
There are two questions.
Yes.
In memo. So from the first one is from Professor Tsui, Hebei Medical University. Right.
Yes.
Okay. To visit Hebei Medical University after the call. Okay. Well, thank you very much. We are happy to visit your university. And Professor Tsui. And next one is from Bhutan, right? CTG facility is available only in hospital. Yes, it is only available in hospital. That's why we developed this ICTZ, right? Which can easily carry to anywhere, right? And then where there are gynecologists, can you comment about the role of CTZ in the health center? Centers without a gynecologist, but with general doctors? Oh, very, very important question. Professor Hara?
Yeah, I think mobile CTG can be used not only in the hospital, but of course in clinic where OBGYN doctor is not there. We can use this system only by even if nurse or midwives only work there, we can use this system. I hope to introduce in such areas our system, a mobile system. And in Japan also at first, unnecessary cesarean section goes up at first. However, correct diagnosis very important to reduce such unnecessary cesarean section. How about, I think Professor Baba think also the same.
Yeah, I think,
late deceleration and early deceleration is different. That is very important.
Hara Sensei, to the second question from Bhutan, I think it says that yeah, so in the centers, in the health centers without gynecologists, but with general doctors. Of course, if general doctors are there, it's of course it's good, but even if no doctors are there in the health center, just nurses, it is okay.
Okay,
It is
very
very
Convenient.
easy to set this the monitor right on the pregnant women's abdomen.
Yes.
So then the signal can be transferred right through internet to the gynecologists who are in the city, so can make diagnosis. So and then even the pregnant women themselves, herself, if they learn little bit, how to use it, they can do it by themselves, right, Professor Ala?
Yes.
Mm.
I think, yes, this is exactly the case in Chiang Mai. So anybody from Chiang Mai
Is
can
there anyone
explain
from
the
Chiang Mai
project?
today?
สวัสดีค่ะ
Sawadee krap.
คนนี้เชียงใหม่ค่ะ
Okay, maybe it's very hard to hear because of the network. Okay. Maybe, yes, some lack of the network connection. So later on, we can send some summary of the project in Chiang Mai via email, because when you apply this session, we've got your email. So we are going to send the case of the Chiang Mai. So in Chiang Mai, 25 public hospitals there are. And then in that 19 hospital is only midwife and the general doctor there. So it means there is no gynecologist. So, but our PuTi CTG installed all the hospital, and then data sent to the other hospital, which means the hospital with gynecologist and OBGY doctor. So it's exactly working in Chiang Mai without the OBGY doctor, so with CTG. So the question from the Bhutan, I think it's yes, but we have to still think about the internet connection in that area. So this kind of device, depending on the connection. So we are going to try that project in near future. So let us involved, please. And Dr. Pema Sensei, do you recommend continuous fetal monitoring with CTG or intermittent fetal monitoring for women undergoing introduction of labor and during labor in low resource country to improve neonatal outcome? 先生、何か答えられますでしょうか。
原先生。
原先生、どうでしょう。質問コーナー。よいしょ。
Professor Hara?
Yeah. I think continuous monitoring is necessary for delivery. Yeah. However, during pregnancy, about 20 to 40 minutes intermittent test is enough, I think. How about Baba, Professor Baba?
Oh, yes, Japan Society of Japan Society of Obstetrics and Gynecology recommends continuous continuous monitoring during the induction labor. Japan Society and also the Japan Association of OBGYN recommended continuous monitoring under the pregnant women undergoing induction of labor. And also, I'll tell you the Dr. Dang Mai Rai from Bhutan, the role of CTG in the health center without a gynecologist. Yes, it's very important. That's because even if the low risk pregnancy, the fetus will easily to distress. So the even if the low risk pregnancy, the CTG is very important to find out the baby at risk.
Okay, so and another question from Dr. Nishizawa.
This is just a comment that to reply to the Dhammaya, to comment that the gynecologist can advise to apply ICTG if the maternal condition suggests compromising the fetal well-being, and data can be interpreted by gynecologists remotely using ICTG, as the data can be shared via mobile network. So that was just to supplement what professors explained to us.
Okay, thank you, Dr. Nishizawa Sensei. So, okay, we got plenty of questions, but if you have any other questions, so we are going to send the email to you with the link of the YouTube, and we had recorded this session. So after we prepared this record, so we are going to send the email with all the link. So then you can reply some question to the doctor. So we pass to the email to the doctor, Professor Baba and Hara. So thank you. So we are running out of the time almost. So if you have any other, you haven't got any other question. Okay. So finally, so we are finishing this session, and please, Professor Tokuda, please wrap up, summarize this webinar, please.
Okay. Thank you very much. I hope you understand that this ICTC mobile CTD is very small but very powerful in rural area. Okay, where many pregnant women are living without having a specialist, so we can help them. And we learn a lot from our trial in Chiang Mai, Thailand, that in the village where no doctors are present, we can just carry it and then can monitor, pregnant women's condition very well. So in the whole Chiang Mai province, with the collaboration of Chiang Mai Ministry of Public Health and Chiang Mai University, we are doing very well. And then the probably next step is to be this project in whole Thailand, whole country. We can do similarly in the other countries, such as Bhutan, Myanmar, Indonesia, and Myanmar, China. Okay, so we are happy to accept the offer of the possible collaboration from you. And then, recently, well, COVID-19 pandemic in all over the world, right? Then we learned this technology, mobile CTZ, ICTZ. If the pregnant women has it at home, she doesn't have to go to the hospital. She can stay at home. Then just periodically can monitor the pregnancy by putting this instrument and send the signal to the specialist doctors who are in the hospital. So he or she can give appropriate advice to the pregnant women. And I forgot one thing which we learned from the Chiang Mai. They used this ICTZ when they transfer the patient to the upper level hospital. So in the ambulance car, they use this mobile ICTZ to continuously monitor the condition of the pregnancy. So that really helps. So the doctors can wait for the pregnant women at the hospital and can prepare, because they can know the condition, the real time. So this really helps a lot. So we can use this ICTZ for such kind of purpose, especially for the emergency purpose. Okay. So we are looking forward to working with you in the future. And then we will probably provide another webinar, and then we can work and we can learn, together in the future as well. Okay. So thank you very much for your participation today. And again, we are looking forward to work with you in the future. Thank you very much.
Thank you, Professor Tokuda. So this is, I guess, that will be all for today. So thank you for participating us. So please see you next time.